Presentation is on heart failure and hypertension tips and tricks of management. I'd like to invite Dr. Naveen Garg, Professor of Cardiology at Sanjay Gandhi Postgraduate Institute of Medical Sciences, Lucknow.
Available for the management of heart failure, and for the control of the symptom we use diuretics and vasodilators. While for the disease modification we have beta blockers, ARNI, MRA and SGLT2 inhibitors. And their use is backed by landmark trials, and adding these agents means adding life. So if you add two agents, it will reduce your 24-month mortality by 37%. If you further add on therapy, give add-on therapy of 4 drugs, you can reduce your heart patient mortality of 24 months by 70%. So adding therapy is adding life. So based on these, the quadruple therapy of ARNI, beta blocker, MRA and SGLT2 inhibitor has been recommended by most of the societies, and they have recommended that these agents should be used in all patients at their recommended target dose. But whenever you increase the dose or add the agent, there is a dose related or agent related drop in the blood pressure. So it is a big hurdle. So this drop in the blood pressure can lead to the stoppage or reduction in the heart failure medication, which can lead to the under treatment of heart failure. And it is quite common. And in the real world setting, every 1 in 5 patients have this problem. And my message is, don't panic if patient of heart failure is having low blood pressure, because the asymptomatic hypotension is more common, and most of these patients are asymptomatic. And it usually recovers with the continuation of therapy, and patient with the low baseline blood pressure, they are benefited the most by heart failure therapy. So never panic whenever you have your patient have a low blood pressure but is not symptomatic. So what is the way forward? That is the topic for discussion today. So I will discuss it in these 4 headings. So first is what are the possible causes of low blood pressure in these patients. So these are the possible causes. The low ejection fraction can lead to low cardiac output and can lead to low blood pressure. That is one of the common cause. And second is hypovolemia, which is very common in these patients, and usually because of the overdiuresis is another cause. And treatment related vasodilatation, because we use vasodilators in these patients, it is also a very common cause. And sometimes in comorbid patients like diabetics, they have altered vasoreactivity, can lead to hypotension or low blood pressure. And now we should identify who are the patients of heart failure who are at high risk. So patients who have low baseline blood pressure, patients who are in NYHA class 4, patients who are having advanced age, serum sodium less than 130, renal function tests are impaired and are getting high diuretic dose. These are the patients we should identify, they are at high risk of developing low blood pressure. So we should also know what is the magnitude of blood pressure reduction by the different heart failure therapies. So different agents which are available to us, the ARNI, AC inhibitor, ARB and loop diuretics. These are the agents which produces moderate to large BP reduction. However, the MRA and SGLT2 inhibitors are quite benign in this direction, and they produce only minimal or no blood pressure reduction. And among the beta blocker, most of the beta blockers except carvedilol, they produces only a minimal or blood pressure reduction. However, the carvedilol is one of the beta blocker which can produce moderate blood pressure reduction. So whenever we have any patient, we should keep these things in mind. So now I will tell you the 10 commandments for management of these patients. My first tip is one should realize that the only symptomatic hypotension should guide the management, because asymptomatic hypotension without end organ perfusion demands only close monitoring because it is not hampering any further treatment, and one should monitor these patients, and one should look for whenever patient is heart failure having a low blood pressure, one should actively look for the symptoms of hypotension, and if patient is having some symptoms of hypotension, then one should link those symptoms with the hypotension, then only you will label that patient is having a symptomatic hypertension. So this is the basic thing for the management of these patients. Now the question arises, how low is too low? Most of us believe that below 90 is too low, but most of the recommendations are below 80 is really low. And whenever you have these patients, one should look actively for the symptoms of hypotension, which are very common in these patients. These are dizziness, syncope, pre-syncope, confusion, easy fatigability. So these are the very common symptoms, and one should look for these symptoms in these patients. And then how to establish that these symptoms are really because of the low blood pressure? Then one has to do two tests. One just take a postural blood pressure test, and ambulatory blood pressure monitoring is also helpful. If link has been established, then you have to prescribe the patient elastic stockings, and one should think about the down titration of the therapy. If there is no link has been established, then these patients should be continued on the guideline directed medical therapy, and they should have a early reassessment of this postural blood test and ambulatory blood pressure monitoring. Another thing is, if patient is having a good blood pressure of 100 or more, but having a symptoms of hypotension. And second is, patient is having a low blood pressure of BP of 90 but asymptomatic, no symptoms of hypotension. These are the two groups one should understand that these patients should also be monitored frequently, but one should not down titrate guideline directed medical therapy in these patients. Another tip is, always identify and correct hypotensive factor unrelated with the heart failure therapy. And if suppose your patient is developed hypotension or low blood pressure after up titration of or introduction of a heart failure agent, then clearly it is associated with the therapy. So in those cases, you have to either stop or down titrate the agent. And suppose you have a patient who is quite stable for a long period and now developed hypotension after a long stable period, then probably this is something else. This is not the agent which is producing hypotension. So in those patients, you should look for these factors which are over-diuresis, diarrhea, dehydration, infection, arrhythmia, recently added some new drugs for some other thing, autonomic dysfunction. So in those cases, identify these factors, correct those factors, and in the meantime, you can stop or down titrate your therapy, and you should restart your therapy after correction of those factors. Another tip is, always identify the hidden hypotensive drugs, which are very common in these patients. And most of the patients take alpha blocker for BPH, intraocular beta blocker for glaucoma, nitrate, phosphodiesterase inhibitor, calcium channel blocker, antipsychotic drugs, anti-Parkinsonian drugs. They are hidden drugs. One should identify those drugs and stop or replace them with the suitable alternative. Another tip is, always try to adjust the diuretic dose. When the patient is not congested, always down titrate your diuretics. And how to do it? Just decrease the diuretic and replace with the MRA or up titrate with the MRA. And in the meantime, you can do a serial BNP monitoring which can assure you that patient is not worsening as far as the congestion is concerned. And one must ask for the salt intake, assess the sodium level, because it is one of the factors which can lead to hypotension. If it is really there, one should give even supplement of the sodium. Another tip is, one should tailor the non-diuretic heart failure therapy. It is required only in cases of persistent hypotension despite correcting everything and correcting the diuretic dose. So this is the final step. And how to do it? Use low dosage of beta blocker, especially other than carvedilol. Use short-acting ACE inhibitor, either captopril or enalapril, and spread your medications. Spread the medication throughout the day. Don't give in the once or twice, maybe 3 times, 4 times, or maybe 5 times. And there should be a distinct gap between the beta blocker and ARNI, and there should be again distinct gap between these agents and diuretics. Diuretics should be in the morning, and ARNI may be in the afternoon, and beta blocker may be in the night. So it may not interact with each other. And at the time of introduction, point to remember is, whenever you introduce dapagliflozin, reduce the dose of diuretic. It is always helpful. And whenever you have to tailor the heart failure therapy, it is according to the phenotype. If you have low GFR, decrease the dose of ACE inhibitor ARNI. MRA may be discontinued or can be stepped down. Or hyperkalemia, reduce or stop MRA. Heart rate less than 60, stop digoxin, ivabradine and beta blocker. If tachycardia is there, tachyarrhythmia is there, up titrate beta blocker and reduce dose of ACE inhibitor and ARNI. Another tip is try to continue SGLT2 inhibitor and MRA in all possible scenarios because they have minimal hypotensive effect and they have a strong favorable effect on the mortality. And it has been shown in the DAPA heart failure study that the effect of this dapagliflozin on the blood pressure was minimal to the tune of 3 to 4 millimeter mercury and the benefit was noted across all blood pressure range. And same thing was noted in the Emperor reduced trial for empagliflozin. Blood pressure reduction was not significant and the benefit was across the board, according to different blood pressure groups. And now we have a diamond approach for the management of heart failure, same as the diamond approach for the management of angina. So they say use heart failure therapy according to the phenotypes. And you can see this is a recommendation from the ESC, the SGLT2 inhibitor and MRA. Most of the patients are eligible for these two agents across all phenotypes. My next tip is if your blood pressure of the patient is stabilized, always try to up titrate. And in cases of improvement, never down titrate, continue the therapy. If blood pressure does not improve despite your full effort, refer the patient to a heart failure clinic. My another tip is try to use all 4 drugs, even in low doses, instead of increasing the dose and reaching to a target dose of 1 or 2 agents. So try to use all therapeutic agents instead of using 1 or 2 agents in high doses. My final tip is if patient is having a really symptomatic hypotension with end organ perfusion, under perfusion, these patients are having cardiogenic shock and you cannot do much. These patients should be put on the inotropic support and should be transferred to a higher center for a heart failure clinic for palliative care, for inotropic support, invasive monitoring, fluid management, device therapy, mechanical circulatory support and positive heart transplantation. So now the treatment algorithm is also available and it is from the European Society and now it has been updated and published in recently few months back in the JAC. They proposed a 5-step approach and the first step is identify the patient and having hypotension, then you link these symptoms with the hypotension and if it is there, then first of all in the first step you should stop or reduce the non-heart failure therapy which may reduce the blood pressure. And if it is not doing anything for the patient, then you have to adjust the dose of the diuretic. And if it is not working, then you have to modify the heart failure therapy. And finally, if patient is not responding, patient has to go for a heart failure team for the final management. And usually maintain SGLT2 inhibitor and MRA. So just to conclude, among patient of heart failure, low blood pressure is very common and is the part of the journey. Only symptomatic hypotension should guide the management. Asymptomatic hypotension demand only close monitoring without down titration of guideline directed medical therapy. Use all 4 drugs in lower doses rather than using a high dose of 1 or 2 agent. Use MRA and SGLT2 inhibitor in all cases because they have minimal effect on the blood pressure with very good mortality benefit. Reduce the dose of diuretic at the time of introducing SGLT2 inhibitor. Individualized care with a step-by-step approach can help to achieve the best guideline-directed medical therapy. Try and try and try again and titrate till drops. Thank you for your patient hearing.
Thank you very much.
Thank you,
We just got
Naveen
one
Garg. It was
question.
very lucid presentation. In a real world, there is no consensus guideline is there.
Yeah.
So if you have started the treatment with drugs and there is a hypertension, it means it is because of the drug.
Yeah.
Then you have to, what you have mentioned, give low doses of all the drugs so that you can prevent the hypertension.
Yeah, yeah,
And
sure.
symptomatic is important.
Yeah.
If it occurs in between the treatment, then it is probably not because of the drug.
Yeah.
Then you have to search for the hypovolemia or other causes of the what you are telling.
Yeah.
Now my question is, it's what is good presentation. What about the elderly patient with orthostatic hypotension? How you are going to approach?
Yeah. In those patients, one has to advise the elastic stockings. Those are very important. And in those patients, one has to be careful regarding the salt intake, because most of these patients, they don't take, actually they stop taking salt, and they are really restricting on the fluids also. So in those patients, we have to somehow maintain this vasodilatation, prevent this vasodilatation and venous pooling by elastic stockings, and just have to maintain this sodium level. If it is, patient is still symptomatic, then you can use now these agonists are also available, and you can use midodrine.
That's all the time that
Any
we have.
comments
Mr.
from the?
Chairman. We probably run out of time for the session, Mr. Chairman.
Okay, Padmanabhan, you can close.
Okay, thank you very
Thank
much,
you.
Mr. Chairman. Ladies and gentlemen, I'd like to thank the chairpersons, the members of the